MIS versus open deformity, they're kind of pros and cons, which we'll compare here briefly. So open deformity cases are obviously really big surgeries. They take a long time to recover from, high complication rate. But it's really faulty to think that you're going to do a big MIS correction and not have it be a big surgery. So it's just something to keep in mind. It's still going to feel like a very big surgery for the patient. You know, there are big surgeries. They're just not as big, right? So the thing that MIS is about the collateral damage that Dr. Uribe talked about. And when you see it really is in the recovery. So they, tend to spend less time in the hospital, less blood loss, and you see them post-op really bounce back a lot faster than they do from open surgery. So open surgery, as I was just alluding to, there's more pain, the recovery is more difficult. MIS is painful, but it's less so, and there's a faster recovery. Obviously, with open surgery, you can achieve an excellent coronal plane deformity correction. But with MIS, there's a really elegant natural correction of coronal plane deformities, and this is through the placement of large lateral interbody grafts. So, obviously, as far as coronal deformity is concerned, you can accomplish the same thing with an open correction. It's just, this is where MIS is really in its forte, as the cases will illustrate. Open correction allows for unlimited sagittal plane correction. Doesn't matter whether the deformity is flexible or stiff. And this is because of the three-column osteotomy. So you can do a three-column osteotomy and really dial in as much lordosis as you choose. With MIS, you can get really impressive sagittal correction, as Dr. Uribe has illustrated with his talk, and it's a much, much less invasive approach. And this is through the judicious placement of anterior interbodies and with use of the ACR. So it's really in, attempting, at least in terms of sagittal correction, to eliminate or limit the three-column osteotomy that MIS really has a big role. But this is limited, right? You're not going to be able to get an unlimited sagittal correction with a minimally invasive approach, and it's also very, it's very user dependent. So what some surgeon is able to achieve this way, someone else is going to have a harder time doing. So with open techniques, there's the intraoperative versatility, right? So it's not always, so in terms of sagittal correction, it's not always, you're not always able to know exactly how much correction you're going to need. And this has to do with the flexibility of the deformity. You can make some educated guesses, obviously, but it's harder to know. And obviously, there's more intraoperative versatility in terms of placing multiple rods and doing other techniques. So the MIS deformity is still versatile, right? So in the process of doing a sagittal correction at a particular level, you can decide whether to do an ACR or not. You can decide whether, in the posterior instrumentation, whether you can do a percutaneous posterior instrumentation, whether you need to do an open approach after you've done your anterior cage placement. And if you do the open approach, you could do a single column osteotomy. So there is some versatility, but I think it's less versatile. The other thing with open deformity correction is you have possibilities of direct decompression and open decompression, right? Everything's open to you. You can decide whether to do an interbody at a level and get indirect decompression, not do a decompression, do a direct decompression. With MIS, direct decompression is an option, but it's something you have to plan for, and you're not really going to get that via an anterior technique. You'd have to access that via posterior approach. So because of that, it's heavily reliant on the indirect decompression. So it's just important to understand that, and that there may be some cases where indirect decompression might not work, and we'll get to that in a minute. So with open surgeries, the fusion substrates are more accessible. The whole spine is open. If you're not doing an interbody, you can do an onlay fusion, whereas with MIS, the fusion substrates are less accessible. So you really need a plan for fusion at each level. If you decide you have to instrument across a long segment, and you haven't done interbodies anteriorly at all those levels, then you have to come back and figure out how you're going to do a fusion level. And there are solutions to that, but you have to have a plan for it. So With open, there are open exposure-related complications, right? Blood loss, transfusion. Infection is so rare in MIS surgery that you can almost think of infection as an open spine surgery complication exclusively. And then spinal fluid leak. Obviously, you can get a spinal fluid leak with in MIS, but it's you're less likely to have open exposed dura with an MIS case. And generally speaking, since the muscle closes around your access point, even if you get a CSF leak posteriorly, it tends to be less of an issue in terms of sealing that leak. MIS has its own specific anterior approach-related complications, obviously, plexus injury, vascular injury, psoas dysfunction, and if you do an oblique approach, lateral approach, sympathetic chain can get injured. And then open surgery obviously has the disconnection, destruction of soft tissue and muscles, tendon and ligament, and these tissues are preserved. The extent to which that is important across a fusion segment is a matter of really still debate. Not a whole lot of evidence there, but at least theoretically, the preservation of the ligamentous envelope can be important. Open deformity is an extension of a familiar skill set. So from a learning perspective, going from open spine surgery for degenerative disease to open deformity is something that's an easier segue, whereas MIS is often a new skill set, although maybe the residents at the Bear are laughing at me because they're so exposed to this that it's just part of their skill set. So I think open in general is more amenable to on-the-fly changes to surgical plan. And this may be psychological. I think with MIS, you tend to get committed more to a surgical plan. It takes a little bit more energy, and maybe this is psychological energy to change it. But I think this is a real thing. So.